Most honorable and distinguished faculty led by Professor Ram Chadda and all our eminent faculty members, Dr. Samir, Dr. Raut, Dr. Shreel, Dr. Ankit, and all our viewers all over the country who are logged in to Bounce Back Webinar Series 4. Today is the final installment in the series of Bounce Back webinars that we've had. And we've had a very encouraging response with more than 600 participants in each of the preceding webinars. As you know, it travels the spectrum of conservative medical management, moving on to the surgical spectrum. And today we culminate with the very important discussion on osteoporosis, which, as we all know, is a very silent killer. And the topic is so eye-catching, silent till it catches our ears and we listen. And again, I think we have an eminent galaxy of superstars here to enlighten us on this topic. So coming on to the next slide. So at Integrace, it's a pleasure to be associated with this Bounce Back webinar with Professor Ram Chadda and all our distinguished faculty members. Integrace, as you know, is a very young organization. Our journey is just 2.5 years young. And in this journey, we have acquired the repute of being recognized as the youngest in top 100 pharmaceutical companies. And we hold leadership position in a couple of therapy areas. Can we move on to the next slide? Like celestazole and even fixed dose combinations of pregabalin, nortriptyline, and mycobalamin. And in these 2.5 years, today it's a matter of great privilege to be trusted by more than 30,000 doctors for the quality medicines that we provide for the benefit of your patients. And we have our operations spanning the length and breadth of our country. Coming to the program for today, as part of the academic initiatives that Integrace has been doing, well, we have pioneered BOOT, the Best of Orthopedic Techniques International Convention. And Professor Ram Chadda himself has been a pioneer in this. He's been a program director on the spine module for all the three installments that we've had right from 2019 to 2021. And it's a matter of great pride for Integrace to have more than 4,000 doctors, in the world and all over the country logging in for the BOOT Live International Convention. We also have done an Indian program called BOOT Web Academy. And we have a repository of latest scientific information called We Connect Health, which you could click to browse all the latest scientific updates and surgical videos to update your skills and knowledge in the field of orthopedics. Yeah, could I have the next slide, please? Yeah, we are also very proud to inform you that as a very young company, we are one of the youngest to be a great place to work certified. And this is in recognition of our contribution to the medical fraternity, as well as the experience that we provide to our employees. Next slide, please. Yeah, it's a matter of great privilege, sir, to have you on board to enlighten us, with your vast experience and expertise in the area of spine surgery. Dr. Ram Chadda is a master teacher par excellence, and he's played a very prominent role in developing the art and science of spine surgery in our country today. And you will see that, all the faculty members who have been there extremely young. And it's a matter of such a great pride that, India is hosting a wealth of young and expert surgeons. And all of them have been developed by Dr. Ram Chadda. So he's played a key role in developing the art and science of spine surgery in our country. So thank you so much, sir, for the human contribution in the field of spine. And anybody who aspires to be in spine would always look up to Dr. Ram Chadda for inspiration. So he's consultant at Leelavati, Jaslok and Global Hospitals in Mumbai, ex-professor and head at KJ Somaya, ex-senior visiting consultant, Saifi, Wockhardt, Fortis, Guru Nanak, Raheja and Apollo Hospitals in Mumbai. Also, Dr. Ram Chadda has been the past president of Association of Spine Surgeons of India, Bombay Orthopedic Society, Bombay Spine Society, a chief national delegate APSS, council member APOA. He has pioneered MICOS, minimally invasive cosmetic spine surgery in India, and he's won numerous awards. To mention a few, the J.B. Modi Gold Medal, Neurotrauma, Spine Instrumentation Fellowship, Münster, Neustadt, Germany, Barrows Neurological Institute Fellowship, Phoenix, Arizona, USA, Nucleoplasty, Freiburg, Germany, Scoliosis, St. Louis, USA, Minimally Invasive Spine Surgery, Seoul, and Korea. So once again, it's a great honor to have your august presence on this dais of Bounce Back webinar series. And without much ado, sir, I hand it over to you to take our audience through the nuances of today's program and give them a gist of what is it that we are going to discuss today and what is it that they're going to take home from today's session. So, sir, it's over to you and thank you so much. Always a pleasure, sir, to have your esteemed association.
Thank you so much, Mr. Anil Fernandez. We are indeed most privileged to be part of these two webinars, TOO webinars, which is being hosted by Science Integra. And on behalf of my entire team, first and foremost, this being the last meeting of this series, we are most obliged for having you to host it for us and being a part of this platform. Thank you so much. Today we talk about osteoporosis, and there is an anagram associated with osteoporosis. The word silent and the word listen are anagrams. They are the same letters. And unless you listen, you will always believe that osteoporosis is a silent disease. To shake up this conundrum, I have with me young blood, which someday would be as old as I am or older, and would face osteoporosis far more aggressively than we do today. I have with me Dr. Samir Ruparel, who's a consultant at the Jaslok Hospital and Global Hospitals. I have Dr. Ankit Patel, who's a consultant at the Bombay Hospital. We have two young men, Dr. Saijot Raut, who's a consultant spine surgeon at various centers in Mumbai, and Dr. Shreel Koirala, working as a part of our team at Lilavati, Jaslok, and Global. I welcome each one of them, and I now hand over to Meenalji, who's going to introduce each one of my colleagues and also share the way forward. And finally, the master of ceremonies would be Dr. Samir Ruparel, who would handhold us and walk us through this journey of osteoporosis. Over to you, Meenalji.
Thank you, sir. So, good evening to all doctors, to the esteemed faculty. It's my privilege to introduce the faculty today. We have Dr. Samir Ruparel. He's a consultant spine surgeon, Jaslok Hospital and Glen Eagles Global Hospital, Mumbai. He has done fellowship of Association of Spine Surgeon of India, Mumbai, and from Australian Institute of Musculoskeletal Research, Melbourne, Australia, and fellowship in minimally invasive spine surgery from Japan. We welcome Dr. Shreel Koirala. He is a fellow spine surgeon at Lilavati, Jaslok and Global Hospitals, Mumbai. He is an ex-senior resident Department of Orthopedics at Maharishi Valmiki Hospital, Delhi. He has done his post-graduation MS Orthopedics from Ramaiah and MBBS from K.G. Kar Medical College. He has special interest in deformity correction, revision spine surgery, and minimally invasive spine surgery. He has done various training programs and various workshops, and he's the member of Association of Spine Surgeons of India, CCOT and Asami. I welcome Dr. Shreel Koirala. I welcome Dr. Ankit Patel. He's a consultant orthopedic spine surgeon at Sanjeevani HCG Asta and Wokhad Hospitals, Mumbai. He specializes in minimally invasive spine surgery, spinal deformity correction, spinal oncology, and he has a vast experience of treating spine disorders of more than 8 years. He has authored more than 20 scholarly peer-reviewed papers and a winner of Young Surgeon of the Year award at Las Vegas SMISS. Welcome Dr. Ankit Patel. And last but not the least, I welcome Dr. Saijot Raut. He is a fellowship in Adult Spine Reconstruction, Mumbai, fellowship in Spine Surgery from Mumbai, fellowship in Scoliosis Research Society, USA, and Minimally Invasive Spine Surgery, Mumbai. He is a life member of Association of Spine Surgery, AO Spine, and Minimally Invasive Spine Surgeon of India, Indian Orthopedic Association. Thank you, Dr. Saijot Raut, for your participation as faculty for this program. I welcome all the doctors once again. Thank you. Over to Dr. Samir.
Thank you very much, Meenal Madam. I once again thank Integra's Orthopedics and Science Integra for having us, the entire team. And without wasting much time, I would start with the first session that is based on osteoporosis, the problem, its evaluation, and the prevention. Before we venture on the medical management, the surgical management, as well as the case discussions. So before starting this session, let's ask a simple question. Why we as spine orthopedic surgeons are worried so much about osteoporosis, which is basically a medical disease. And spine surgeons, as you know, are very much interested in doing surgeries. So what's the worry? This is because osteoporosis is rampant. It is so rampant that in age group of more than 50 years, 1 in 3 women and 1 in 5 men are affected by it. This means that close to 20 to 35% of the geriatric population is affected by it. And on top of it, 15 to 50% of the population suffers from osteoporotic fractures. So we are going to have a large population, as much as 2 to 3 folds in the near future, who is going to get affected by it. And when such patients come to us who are orthopedic spine surgeons, they are really difficult to manage at one point of time, because these patients are really old, they have comorbidities, they need larger surgeries, extensive implants and metals within, and have higher complications rates. For example, this is a patient who is a 63-year-old female who came with a trivial trauma, jerk while traveling, and came with complaints of low back pain. And as we can see, there's a mild L1 osteoporotic vertebral fracture, which was conservatively treated by the normal protocol, 3 weeks rest and 3 weeks of restricted activity. But this is what happened at follow-up. And can we prevent this? As we know, the fate of an insufficiency fracture is most of these fractures heal, but they heal with a bit of collapse and as well as deformity. But sometimes not all of these fractures heal. They may have non-unions, they may go into pseudoarthrosis, they may develop instability, cause pain, they may also cause neurological deficit and loss of function. And those which don't heal are difficult to treat surgically. And it is very much necessary, just like tuberculosis, to treat this osteoporosis at the same time as we treat these patients surgically. It is well said that prevention is better than cure, but how? Now, there are 2 ways to prevent osteoporosis. One is increasing the peak bone mass from childhood and treating at the first contact, just like diabetes and blood pressure is being treated these days. Now, let's come to the point, how can we increase the peak bone mass? The peak bone mass is mainly attained by an individual at skeletal maturity, that is 25 to 35 years of age. So, after the peak bone mass is achieved, both males and females lose bone mass over a period of time, and it is a very important factor in the development of osteoporosis. The 2 factors that are modifiable and needs to be taken care of right during the teenage years is a good nutritional status of the children, as well as involvement in good physical activity. As you can see, the peak bone mass in women is much less as compared to that of men. And after menopause, they lose as much as 5% of peak bone mass per year, which is quite significant. So the figure illustrates that the change in the bone mass throughout life shows a rapid bone loss that occurs in women after menopause, as you can see over here, which is far more as compared to men. And in women, estrogen deficiency is a major determinant factor of bone loss after menopause. And hormone replacement therapy has been propagated as one of the ways to reduce this loss of bone mass in women. But currently it is on the wane because it gives rise to more side effects than benefits. Now, we do have SERMs, which are selective estrogen receptor modulators. This is a non-hormonal option and has shown to have good to excellent results. Now, coming to treating it at the first contact, just like diabetes and blood pressure, you will be amazed to know that only 15% of the patients are treated after an osteoporotic fracture. A fracture is analogous to osteoporosis, what a heart attack is to a cardiovascular disease. And 10 years ago, this was a state of patients with myocardial infarction. And The other known fact is 60% of a women with fragility factors have non-osteoporotic bone mineral density, that is T-score of more than 2.5. Now, what are the ways of preventing it? Non-pharmacologic treatment, as we all know, dietary changes, calcium contributors, a diet which is rich in milk and milk products, as well as sunlight exposure, fatty fish, and few unfortified foods are good contributors of vitamin D. Similarly, lifestyle modification with emphasis on weight bearing and muscle strengthening exercises rather than the aerobic exercises, which improves the bone strength by almost 30 to 50%. And this should be lifelong, along with cessation of smoking, alcohol, caffeine intake, and adequate sun exposure. This is very important, prevention of falls. And exercises for balance training, correction of sensory impairments, reducing the environmental hazards, and education in individual about behavioral strategies. Now, men at the age of 50 to 70 years should consume about 1000 milligram of calcium per day, as well as women should consume about 1200, and intakes excess of 1200 to 1500 may increase the risk of developing kidney stones or cardiovascular disease. And most of the supplements which are available in the market, they have only 500 milligrams of elemental calcium. Coming to vitamin D, the normal supplementation is about 60,000 international units per week for about 8 weeks, followed by 60,000 international units per month, followed by that should be taken up for at least a year. Now, how do we manage? How do we identify what are the symptoms and signs of this patient? What are the differential diagnoses? What investigations need to be done in this patient? Is DEXA scan really necessary? And in which patients should we start the treatment? As we all know, it is basically a silent disease. It usually just causes low back pain, which is mild. There is loss of height and kyphosis. Sometimes the patient comes with fractures, which are most commonly found in the lower end of the radius, the vertebral fractures, or the hips. And there are numerous differential diagnoses or the secondary causes of osteoporosis, which may be hyperparathyroidism, there may be osteomalacia, osteogenesis imperfecta, or multiple myeloma, secondary tumors, which may mimic the radiological appearance of an osteovertebral fracture. It is very much necessary to rule out the secondary causes of osteoporosis, the most common being diabetes, hyperparathyroidism, hyperthyroidism. There may be some underlying malignancy. There may be nutritional deficiencies, some medications which are commonly prescribed like proton pump inhibitors, excessive thyroid hormones, or steroids, as well as tobacco use, chronic liver disease or renal disease, and malabsorption syndromes. It is very much necessary to ensure that loss on bone mineral density is not due to secondary causes of osteoporosis. Hence, there is a battery of biochemical tests that need to be done in a patient in whom osteoporosis is being suspected, and this is a list of it. Now, when a patient comes with a collapsed vertebra, it is basically a dilemma for the consulting physician. As you can see over here, this is a 69-year-old female who is more than 20 years postmenopausal and minus 3.9 T-scores with no neurological deficit, showing a collapsed vertebrae. What is the diagnosis over here? It is very much necessary that in elderly patients, it is to rule out tuberculosis, a metastasis, or myeloma, which may mimic an osteovertebral compression fracture. But how? Through history, any history of fever, weight loss, anorexia, or rapid progression of back pain, any of the red flag signs which were discussed previously, a proper physical examination. Look out for the common sites of metastasis, the most common being the lungs, the breast, the kidneys, the liver, and the prostate. An extensive investigation which involves radiology as well as the blood tests. The X-rays are very subjective to diagnose osteoporosis per se because they are dependent on numerous fractures, and at least 30% of bone loss needs to be present before we can diagnose it on the X-rays. And hence we come to DEXA. There are two scores in DEXA, the T-score as a Z-score. We are all aware of the T-scores, but many times it is a Z-score which is important since it is based on the age-matched group, and it differentiates the primary osteoporosis from the patients who are having secondary osteoporosis. Hence, it is very much necessary to look at the Z-scores of the patients as well. Screening of osteoporosis, when should the bone mineral density be done? At age more than 65 years, it is recommended that everyone should undergo a DEXA scan, as well as in those patients who are less than 50 or more than 50 to 65 years, having one or more of these risk factors. Based on the eligibility of the drug therapy, there is a FRAC scoring which has been developed recently by the World Health Organization, and this has been the modalities of treatment that is necessary. If the FRAC score is less than 10% recently, then lifestyle modification is advised. Those which are more than 20% risk, it is necessary to treat it with medications. And there are top 5 reasons for those patients those who are between the 10 to 20% patients. And these are the reasons in whom that we should consider starting an anti-osteoporotic treatment. Those patients having falls or a secondary risk factor. Now, there are numerous treatment options being medical as well as surgical. As you can see, the most common being the bisphosphonates, the denosumabs, and the teriparatide. And similarly, there are numerous surgical options which are available, which range from fixations to simple vertebroplasties. And this is going to be discussed in the coming sections. Thus, the take-home message from my presentation is the prevalence of osteoporosis is dampened. Management of osteoporosis is fractures is very difficult, and it is very much necessary to take active measures to prevent and treat osteoporosis right from the start. Thank you very much.
Thank you very much, Samir. Now we'll go on to the case discussions, or are we going on to the medical management first?
So we will discuss the medical management for which we have Dr. Saijot Raut with us.
Hi, good afternoon, everyone. So, Dr. Samir has given us a good review of the osteoporosis. I am going to talk here about some important message about the osteoporosis and also about the medical management in the osteoporotic spine. So let's see what is the medical management of it. So we have a case scenario where there is a 68-year-old female who is obese, hypertensive, diabetic, had a fall in bathroom, had severe back pain. Her previous DEXA is to be minus 3.1, which was 6 months ago. We all will conclude that this is an osteoporotic fracture, and we will treat it conservatively as because her DEXA and all her age and everything is on the side of osteoporosis. But we made a mistake. This patient, when we conservatively, and we gave a bed rest, support, everything which we could, NSAIDs, calcium, D3, bisphosphonates, and turn out to be a meds. So message here is that not every fracture of postmenopausal woman is osteoporosis. We should have a high index of suspicions in elderly. Osteoporosis is a diagnosis of exclusion, and treat all patients with high risk factors. All collapsed vertebrae should be seen with suspicion is the message first. So now how do we approach a collapsed vertebrae? So we do a baseline lab profiles first, liver, kidney profile, serum protein electrophoresis, bone scan, tumor markers, and SOS CT guided biopsy if needed, if there is a suspicion. So first rule is all elderly with fracture having osteoporosis, treat osteoporosis, but not all fracture in elderly are osteoporosis related. The investigation which you can perform, like I mentioned, is blood, liver, all the serum protein electrophoresis, and the urine reports. So we have to find out if there is any secondaries. Many fractures will lead into secondaries, and osteoporosis again a diagnosis of exclusion. Osteoporosis almost heal always, so don't be aggressive to treat aggressively. Always medical management helps. So what is the treatment of osteoporosis? 80% of the time osteoporotic fracture heal, but there is only non-union seen in 30% of patients which develop Kummel's lesion, and there is a neurology in 6% of these osteoporotic patients, which is also late onset neurology sometimes. So now general care is also a part of medical management. Improve muscle tone. Muscle tone, as in the osteoporosis is not only a disease of the bone. It also requires a high protein diet for the muscle mass. Patient should be prevented from falling. There should be adequate lighting at home. There should be care to avoid postural hypotension. There should not be any loose rugs. Railings should be installed in the bathroom for the support of elderly. The floor should not be wet, and there should be correct eye sights. All these are the preventive measures for the fracture. Now coming to the medical management is key to success, but we have these dilemmas in our mind: when to start, which drugs to be started, how do they work, is combination or solo therapy required, and how long to give these drugs, and how to monitor when these drugs are given. So for all these questions, I have answers in the coming slides. So there are these all types of osteoporotic medications. First kind of osteoporotic medications are anti-resorptives. Bisphosphonates, that is alendronate, risotronate, abendronate, zoledronic acid are bisphosphonates. Second type of anti-resorptives are denosumabs. Next is anabolic agents, which is teriparatide. And third types are hormonal therapies, which are estrogens or relaxifene. Now, still under development of medications are strontium therapies, anti-sclerostin antibodies, cathepsin K inhibitors, and the last is all these combination drugs. So, how do we do all this? So, first is, like I mentioned before, there should be prevention of the fall modality. Second is maintain adequate intake of calcium, preferably from the diet. Calcium supplement should be daily intake of 1000 milligram. And vitamin D supplementation, avoid vitamin analogs, use vitamin supplementation, increase weight bearing exercises, encourage patients should be mobilized to improve the muscle tone and the muscle mass, and patient should be kept on high protein diet. Now, basic rule for medication is start at earliest. Medical management should be started at early as possible to reduce the fracture risk. So don't wait for the fracture to come. Start your medications. Fracture healing is not the primary goal. General care should not be neglected. So now, anti-osteoporotic medication, no empirical treatment. Baseline workup is mandatory to check the feasibility of the use. To use bisphosphonate, teriparatide, and denosumab. Feasibility use, before you start, you should check the calcium level, PTH level, alkaline phosphatase level, creatine level. You have to check for asthma, gastric issues, blood thinners, and frequent follow-up should be done to check calcium monthly and BMD, which is 12 monthly if there is a failure of therapy. Now, anti-resorptive, which is the first line of treatment. Why? Because it prevents bone resorption. It reduces the osteoclastic function, both the bisphosphonates and denosumab. Both denosumabs, they form the rank ligand, and they reduces the osteoclastic function. They do not form the bone. So the options which we have available is multiple options. They are weekly, monthly, 6 monthly, and yearly doses. Bisphosphonates and denosumabs. Now, bisphosphonates are the primary drug because they prevent reabsorption. They are usually used in menopausal patients. Menopausal patients, they are principal use. 24 weeks of exposure is can be given of bisphosphonate to the patient with osteoporosis. Primary baseline workup, as I mentioned, should be important. So now, where should not be used bisphosphonate in acute fractures in young patients. And we always have to check calcium levels, creatine levels, asthma, gastric issues, blood, if patient is on blood thinner. Frequent follow-up should be done to check calcium 3 monthly, BMD 12 monthly, and not more than 5 years. Now, second is denosumab, which also prevent bone resorption. The mechanism is similar to bisphosphonate. It blocks osteoclasts. It should be given once in 6 months. And most important is bisphosphonate. It can be given as a combination drug. The advantage of it is once in a 6 month and combination drug. It can be used to do maintenance also. If there is a failure of one drug, it is used. In severe case of PTH resistance, where we cannot use any other drug, where we can use denosumab. And it is most important in secondary osteoporosis also. It can be used for more than 5 years, unlike the other drugs. So what is the efficacy? They increases bone strength, reduce fracture risk, more in hip than spine. The duration is more than 24 months, and side effects has to be monitored. Now coming to teriparatide, it's a bone forming agent. So it's best in secondary osteoporosis. It stimulates the osteoblastic activity, enhances skeletal architecture. So what is the dose? So dose is a 200 microgram daily dose of pulsar therapy. Route is injectable. It is given subcutaneous. It can be given in multiple sites: thigh, buttocks, thigh, and abdomen. Duration of therapy is 24 months, 3 months, or 6 months. 6 months of use, and it should be avoided in children's patients with radiation to bones and Paget disease. What are the contraindication? Contraindication is you always check serum calcium, serum PTH, creatinine, alkaline phosphatase before giving it, and to rule out infection and meds before giving the teriparatide. So what is the efficacy? There's a paper called dose dependent efficacy of parathyroid hormone on fracture healing. It stimulates the bone formation. So it has been shown it stimulates bone formation and helps in fracture healing also. So which one to start when? When a patient is asymptomatic with DEXA score of more than -3, if the DEXA score is beyond -3, more than -3, then we can give bisphosphonates, which is weekly. If the fracture or if there is a fracture or if the DEXA scan of patient is T score showing less than -3.5, then we start teriparatide daily, which is an injectable subcutaneous injection, and maintenance therapy or patients where there is contraindicated bisphosphonates, denosumab can be given once in 6 monthly. So how long can we give this? Osteoporosis is a lifelong problem. So bisphosphonates can be given for 2 to 5 years orally. Therapy is 24 months, maintenance is 60 months, and exposure is not more than 5 years. Teriparatide subcutaneous can not more than 24 months, and denosumab subcutaneously lifelong maintenance 6 monthly interval. How do we monitor this? How do we monitor? So these blood tests like calcium and versus bone markers versus DEXA scan, which one is effective? So serum calcium 24 hours after injection, calcium level once for 3 months we should do. The role of now there are roles of bone markers also, bone formation marker P1NP, bone resorption marker serum and URNTX. Protective effect starts after 9 months of therapy. So we should do BMD only after 1 year and decide if the therapy is working or not. So now, should we do a solo or a combined therapy? What is the efficacy? So this paper shows that there is always a role, the anti-resorptive agent is superior to monotherapy, and this is the paper which shows that. So when do we change the therapy? So if the treatment is failing, if there is a decrease in BMD on the treatment at 1 year, after 1 year also, if you see that BMD is decreasing, or there are one or more fragile for some other factors also, there will be new risk multipliers, change in medication. So the last message for this slides are, the medical management for osteoporosis is not empirical. We have to start the therapy as early as possible. We have to monitor them. We have to check for responses and we have to maintain them. It heals fracture. It prevents new risks of fractures. General care for patient to be given and they have to be prevented from the fall is equally important in this management. And failure of therapy should be monitored and documented timely. Thank you so much.
Thank you very much, Saijo. Thank you very much, Samir. Both of you have given an excellent introduction and you've set the ball rolling. Now I think it's time to exercise our decision-making skills, and it's over to you, Samir.
Thank you so much, sir. I think we'll then start with the case discussions, and I may invite Dr. Shril Koirala to present the first case.
Yes, sir. Good afternoon, everyone. I'll be presenting a case of osteoporotic vertebral compression fracture. We have a 75-year-old lady who was previously operated by us for L3-L4 degenerative listhesis. We had fused her L3-L4 with a mesh cage. She complained of pain in the mid-back for 4 months after a trival fall at home. The pain persisted in all positions, whether the patient was sitting, standing, lying down, changing postures at bed. She also took 3 selective nerve root blocks over the past few months for the same pain. She was hypothyroid, hypertensive, diabetic, and had restless leg syndrome. She also had a history of CABG done in the past, and she was postmenopausal for 36 years. On examination, there was tenderness present on the thoracolumbar area. There was no motor or sensory deficit yet, and the changing postures were painful. Having examined her and from her history, there is tenderness in her back. There is no motor deficits. She is an elderly lady with a lot of comorbidities, and she is not able to perform her daily function. So what could be the clinical diagnosis?
So what do we have the options as a clinical diagnosis, Dr. Shril?
It could either be a vertebral compression fracture. It could either be a tuberculosis, which is common in India and Indian subcontinent. It could be an acute or a chronic infection. It could be tumors or multiple myelomas.
Right. And so, how do we differentiate these?
Yes. So when a patient comes to us, an elderly lady comes to us with even a tribal fall and a pain in the back, we need to investigate her with blood investigations, like Dr. Saijut Rautsa advised us, X-rays, MRIs, and CT scans. Blood investigations, we would want the whole hog. That is, we would want serum vitamin D levels, calcium levels, creatinine levels. We would want to work on a multiple myeloma profile. We would also want to look at the arthritic markers.
So I may ask Dr. Ankit over here. So this is a very obese elderly lady with multiple comorbidities who has sustained a fall, and since then she has mechanical back pain. As per Dr. Sheel, he would like to run the whole hog of investigations, right from blood tests to X-ray and MRI. So in your practice, Dr. Ankit, would you like to run all the investigations, or you would just settle down for X-rays?
So when the patient will present to me first, I will like to do an X-ray and try to locate the cause of the pain. And once if I see a fracture and if I see there are multiple old healed fractures or anything else which is suspicious, I will like to investigate further in that direction. So usually a basic blood profile plus an X-ray, try to localize the lesion, and if suspicious, investigate further.
Right. So can we have the X-rays, Dr. Sheel?
Yes.
Or the blood test reports?
So we did have blood investigations. Her vitamin D3 was low, B12 was low normal, myeloma profile was normal, and arthritic markers were negative.
Right. So what all tests in the myeloma profile do you usually advise?
We do a serum protein electrophoresis for M band. We look for M band or any other gamma globulinopathies. We also look for free kappa and lambda chains. And we also, the most important is we look for kappa lambda light chain ratios.
Right. So that essentially rules out myeloma in most of the patients. Right.
This was her X-rays. We had previously done a lower segment fusion with mesh cage. According to the radiology, this is a sacralized L5. So this is a L4, L5 stabilization down below. And up fourth vertebra from the last instrumented vertebra, we can see that there's a collapse in the sitting, and in supine we can see that there is a vacuum cleft sign seen on D11 vertebra.
Right. So Dr. Sai, when do you usually prefer to do sitting supine, or you would have just gone for a plain simple X-rays, the DL spine AP lateral?
So usually in this, where we suspect there is a osteoporotic fracture old and non-healing, we usually go for a supine and sitting. Obviously, where we cannot do a flexion extension and where patient is painful, we do a supine and sitting lateral X-rays to see the see if there is a cleft sign, exactly how it is shown in the X-rays, if there is any vacuum or cleft sign, before going for an MRI.
Right. What are the things, Dr. Sheel, that you see in this X-ray, and what do you suspect?
So now what we see is we see that the lower fusion is well, the implants are well in its place. There is no breakage or there is no any loosening of the implants, and there's a good union going on down below. Up in the vertebral fractured level, we can see that the vertebral body is collapsing and expanding, and there is a cleft sign which is seen. Now this shows that the fracture is now going into non-union, or even there is a bone necrosis happening in the vertebral body.
So this is basically a pseudoarthrosis.
Yes.
So I have one question for Dr. Sheel here. So do you always look at the location of the fracture in terms of whether it is in the thoracolumbar region or it is in the mid-thoracic region? And does that have any impetus on how the fracture might heal or progress further?
Yes, sir. So what we believe is thoracolumbar fractures are more important to look for and diagnose, because it gives a progressive kyphosis if not treated otherwise. And the lumbar spine fractures could be managed with a conservative trial, but the thoracolumbar fractures are notorious to go for a non-union or a progressive kyphosis.
If you have had this patient early on, and you had thought of doing a conservative treatment on her, what kind of bracing would you prefer? If she's not a very obese lady and she can wear a brace, what is the brace of your choice?
So yes, so to prevent the kyphosis, we would prefer her on anterior hyperextension brace.
Okay, great. So does this morphology of the fracture here, does it make you worried? Like, is it a normal morphology that you're seeing, or is it a bit different as compared to the normal thoracolumbar insufficiency fractures that you see commonly?
The morphology here is a bit different, sir, because here what we see is that the fracture line runs just below the inferior plate of the vertebra, which on the first day could be a telltale sign of non-healing, which could decide that the fracture can go to a non-healing phase.
So exactly that might be a component of end-plate fracture as well here. And
Yes.
usually we have a fracture which is usually on the upper half of the body,
Yes.
which ends up in a saucerization and collapsed healing.
I would like to ask Dr. Samir and Dr. Ankit, if you see such fractures, end-plate fractures, where do you always do a CT scan before doing anything, or you just do an MRI?
So here an AP X-ray also will put a lot of information on the table. If we see widening of the edges and if we see splaying of the pedicles, that means that it is probably an unstable fracture, a kind of a burst fracture along with the insufficiency fracture. And a CT scan would help if we are planning a procedure.
For vertebroplasty, what do you do? Always do a CT scan, or you just go ahead with the vertebroplasty?
So usually the first investigational choice is an MRI because that will give us information about the spinal cord as well, and you can pick up telltale signs of posterior body wall collapse, a break, or a pedicle or body junction break. And if you suspect and if you're doing a vertebroplasty, standalone vertebroplasty, a CT scan definitely helps.
I think X-rays are the primary investigations, as rightly pointed out by Dr. Ankit, that the AP X-ray as well as the lateral, both of them cumulatively will put a lot of information with us. And for me, MRI would be the second investigation of choice to look at the soft tissues as well as the status of the spinal canal. CT would probably will pay more emphasis if I am planning a procedure like a vertebroplasty. But before we jump on to further discussion, Dr. Ankit, so suppose this lady would have come to you on, in the first week of trauma. What are the peculiar features that you probably see on the X-rays that would suggest that this lady has a high chances of going into non-union?
So as I spoke earlier, I usually try and see what is the type of morphology of fracture line. Okay, so if it's an atypical fracture, or if I see there is splaying of the pedicles or ballooning of the posterior vertebral body, I suspect that it is kind of a burst rather than a pure intravertebral insufficiency fracture, and I will be very much suspicious and will be having her in a follow-up frequently.
Right, but you will continue with the conservative treatment and the general osteoporotic treatment that we are going to put.
Yes.
Okay, and so if this lady would have come up to you in the first week, what would be your line of medical management in terms of general counseling as well as in terms of the medicines that you would prescribe?
So first, on the X-rays, I will like to see if it's a primary osteoporosis or a secondary osteoporosis. If I suspect a secondary osteoporosis, as mentioned by Dr. Sheel, I will go the whole hog and do a complete investigation gamut. If everything comes normal, I will put her on restricted activities, not complete bed rest, but yes, with brace restricted activities for the initial few weeks. Start her on biphosphonates and patient-decided analgesia. And then observe her for the next 3 to 6 weeks. If at the end of 3 weeks and at the end of 6 weeks, the pain scale is steadily going down, the patient is a bit better in terms of mobility, and the serial X-rays are also holding well, then we can continue. But if we see on serial X-rays at 3 weeks and 6 weeks, there is progressive collapse, or if the pain scales are not improving, then we should investigate further.
Right. So, Dr. Sai, when the patient comes to us, any role of calcitonin nasal spray in these patients? Dr. Sai, we can't hear you. Maybe you are muted.
Samir, you need to repeat the question. I think he didn't hear whether there is any role of calcitonin nasal spray.
So can we have Dr. Ankit answer that question for us?
Yes, calcitonin nasal spray definitely helps in terms of general bone pain. But if the patient has specific tenderness and specific pain related to that fracture, it cannot be of much help. But yes, patients who have had multiple osteoporotic fractures, which we have seen have healed and are in a process of healing, a nasal spray treatment for a few months definitely helps.
Right. And how much amount of bed rest do you usually prescribe to the patient? Is it like 3 weeks, 3 days? There's a huge amount of difference in the literature which is available presently.
I'm strictly against any strict bed rest. If the patient can wear a brace properly and if comfortable in a brace, we should advise mobility, restricted mobility at least for bathroom visits and in the home.
Right. One of the other questions that patients commonly ask in the clinic is, do we need to put the patient on a hard bed or, without any cushion or something?
So that's not required. A firm bed without much sagging inside the bed is okay.
It's okay. Right. So this patient has now come to us who is at 3 weeks showing signs of non-union on the x-rays. Dr. Shield, did we get any other further investigations?
Yes. So what we did is we went ahead and did MRI, which showed us that there was a non-healing fracture at D11 level. These are the axial cuts of the same, and which shows that anteriorly, although the cortex is almost maintained, there is a bit of necrosis going on at D11 level. We also got a CT scan which confirmed the Kummel signs to be positive, and there was a osteonecrotic area in the vertebral body, which showed which proved the diagnosis of going into a pseudoarthrosis or a non-union. We also did DEXA for this lady, and the DEXA showed a minus 2.5 T-score in the left neck of femur.
So, Dr. Shreel, this is a very old lady. Was this lady previously on any anti-osteoporotic treatment?
The lady was advised anti-osteoporotic treatment in the past. She had taken bisphosphonates, but now she was in the she was in a medicine-free time, sir. She had not taken currently.
Right. So probably, in this patient, I would have expected the DEXA score to be much more. She is 70-year-old postmenopausal lady since last 32 years. But the DEXA score or T score of minus 2.5 is pretty good for her. But I suspect that there are some secondary factors like diabetes also which are present in this patient, for which we need to be aggressive in treating this osteoporosis.
Yes. So in a patient with diabetes and other comorbidities, we need to see that minus 2.5 would not be the cutoff score of T-score in DEXA. We would consider minus 2 in a diabetic patient to be the cutoff score.
Right. And we will be aggressive in treating this patient.
Yes, sir.
Right.
So what next? What should be the next line of management? Do we go for a conservative management with bracing, lifestyle modifications, NSAIDs, anti-osteoporotic drug therapy, or do we offer her surgery, or do we do both? What would be the next line of management?
So, Dr. Sai, what would be your call? Continue with the conservative management, or shall we contemplate surgery?
Patient, she has pain, and if her ADL is affected, I would like to start her. I would give her an option of surgery, with also starting her on the anti-osteoporotic therapy.
So this time the lady. So what is the anti-osteoporotic treatment? So she has previously taken bisphosphonates, and she was on a treatment holiday. So what are the? Will you continue with the same bisphosphonates with the DEXA score being minus 2.5? Do you think that there's a failure of any osteoporotic treatment here, that you would be more aggressive with it this time?
I think we should start her on the anti-resorptives, which is she's already on bisphosphonate. You said we can start her on the PTH and injectable, which is, and also after post that we can start her on the maintenance dose of denosumab.
Right. So, Dr. Ankit, any role of starting combination therapy in such patients, or would you go only with the monotherapy?
So yes, combination therapy helps, and I will definitely try and add one more drug with the biphosphonates.
Right, right. So, what will be the surgical options on for this patient? Dr. Sheel, can you show us the options?
Yes, sir. So we could either go for a vertebroplasty, we could either go for a posterior stabilization with anterior column reconstruction, we could also go for a posterior stabilization with vertebroplasty, or a minimally invasive posterior percutaneous stabilization with vertebroplasty.
So, Dr. Ankit, what would be the procedure of choice for this patient?
For her, if I'm seeing here a very small defined cumulus lesion without any obvious posterior break, I will either stay on the side of only vertebroplasty or vertebroplasty with posterior stabilization, depending upon the patient's pain. If the patient has severe pain, and if I see any signs of subtle postural element laxity or injury, I will definitely go a bit ahead and put in percutaneous screws there, do an MIS fixation with vertebroplasty.
Right. Do you usually recommend to supplement posterior percutaneous stabilization of screws in patients with vertebroplasty?
No, if the collapse is not more than 50%, a standalone vertebroplasty also helps. But the patient should be made to understand that there can be early failure of the vertebroplasty, and then we might have to revise. So the patient can understand that the vertebroplasty standalone can have failure if the medical management doesn't take over and fortify the bones, then we might have to reinforce. So that's the patient's and doctor's call. Just to be taken after a mutual consent.
Right. So, Dr. Sai, what would be the indications of vertebroplasty in general for the benefit of the audience?
If here I would like to, we could do here a vertebroplasty with a MIS, like Dr. Ankit told me, that it is posterior percutaneous stabilization can be done. Or if we have to go and fix, we could do also a bone grafting inside the lesion.
Okay. So, but in what patients generally, based on the radiographs and the patient's profile, in what patients would be indicated a true indication for vertebroplasty, and in what patients you would probably not think about vertebroplasty? Like over here, the consensus of the house is that, as per Dr. Ankit, as per yourself, that vertebroplasty is a suitable option in this patient. So, what are the things that you saw in this patient that you probably think that vertebroplasty is good?
So I think the one thing which would decide if we have to go for a vertebroplasty and a fixation would be the X-ray which we saw the sitting and supine X-ray where there is opening up. And if you have any doubt if the vertebroplasty would not hold, I would go for the fixation, and depend upon the pain value and pain factor of the patient also.
Right. So, Dr. Ankit, any contraindications of vertebroplasty?
So as I said earlier, if I see on the X-ray that there is any signs of burst component like a posterior wall ballooning or splaying of the pedicles, or if I see that the opening up is more than like 50% on supine setting, that means that the void is too big and the cement that we inject can act like a hard ball inside a soft shell. So, and in that selective cases, I will differ from going and doing a standalone vertebroplasty.
Okay. So let us ask Ram sir, what would be his treatment of procedure in this patient? When will he prefer to do a vertebroplasty, supplement the vertebroplasty with the posterior fixation, vis-a-vis go for the whole hog, go for a posterior stabilization as well as decompression?
This lady classically has transition pain. She has pain while getting in and out of bed, which has been bothering her for some time. There is a non-healing, but the cleft is small. It's not a large void. But what I understand is she has a medium demand back, and she has an anticipated quality and quantity of life. She is a person who may be fit for a general anesthesia procedure and is not one of those who's absolutely unfit for a GA procedure. Now, if I have patients who are absolutely unfit for a general anesthesia procedure, then I have a low threshold for vertebroplasty or cement augmentation alone, quick in, quick out, and call it a day. If, however, there are higher demand patients who are fit and in whom I am putting in cement, I tend to augment it with a percute posterior tension band in addition, because I have had situations where I put in cement, and as mentioned by Ankit and Sai, that they tend to become a hard ball within a soft shell, and they tend to crumble or crush around, or they cause adjacent segment fractures. So today, unless it's a very, very sort of poor medical morbid patient, I would most of the times augment my vertebroplasty with a tension band if possible, especially at thoracolumbar junction.
Right, sir. So, what was the procedure done, Dr. Sheel?
So what we did is we did vertebroplasty with percutaneous stabilization, one level above and one level below.
Okay.
We did the vertebroplasty was done with two CM machines, used AP and lateral simultaneously, locating the pedicle of D11 vertebra, and then the Jamshedi needle was inserted from the pedicle to the vertebral body, and about 1 to 2 ml of vertebral cement was inserted into the vertebral space, and we can see here that it is well contained inside the vertebral body. The pedicle screws were inserted on a percutaneous basis, and these are the towers and serial dilators which were used for percutaneous screw insertion. This is the post-operative wound of the patient with percutaneous stabilization and vertebroplasty. And these are the 6 months follow-up images.
Right. So, Ram sir, any particular precautions while performing the vertebroplasty procedure?
Well, precautions that you need to take while performing vertebroplasty procedure are quite a few. One, please do not over-inject cement. I do not go more than 3 to 4 ml ever in the thoracic spine. In fact, less than 3 at times in the thoracic spine. That's one. Second, do it very, very slowly and wait after the initial injection so that you can see if there's any leak either in the intercorporeal area, retrocorporeal, or if it is extrapolating into the blood vessels. So you could go slow. Third thing, which is very, very important, is to inform your anesthetist that you're doing this procedure so they'll keep the patient's blood pressure well maintained. Having said that, your cement needs to be refrigerator, even the best cement, before you get in, so that you have more time to use it during the procedure. So these are the basic things that I tend to do. Again, a pre-operative planning, whether you're going to do a biportal or a uniportal, needs to be taken. If the Camel sign is eccentric, you may be able to do a uniportal. But if the Camel sign shows that there is a void bilaterally, you might have to put in 2 needles. So these are the various things that I look at. And as I said, this is a temporary pain relieving procedure. This is not a bone healing procedure. Hence, smaller voids would work. Larger voids are very, very difficult. So if you feel you've done a great job and you've injected 6 ml of cement, well, you're asking for trouble sooner or later.
Right, sir. Sir, and before concluding the first case, can you give us a gist of the medical management of osteoporosis, particularly with this patient who had been previously on bisphosphonates, DEXA score of -2.5 only, and what would be the further line of medical management, particularly in such patients?
Well, I look at few things. One, I look at the lowest T-score, which in this lady is -2.5 in the left femoral neck. Besides, if a -2.5 is in a diabetic, I interpret it as a -3. Having said that, presence of a fracture makes osteoporosis severe. So for me, this is a lady who needs teriparatide. I'm very clear about that. Yes, I would check her serum parathormone. I would check the fact that she's not had malignancy or is presently harboring malignancy in the body. And if so, counsel her for 2 years of subcutaneous 20 micrograms of parathormone on a daily basis. If she's a high demand patient, I would also do markers like P1NP, which can be repeated at 3 months to check the progression. If not, I don't aggressively use markers now as I used to do them in the earlier days. And if this lady is like a -2.5, I may use teriparatide for 2 years and then jump on to denosumab for the next 10 years. If, however, she had severe osteoporosis,
which is a minus 3.5 or a minus 4 to begin with. She was treatment naive. That means she's not taken anything in the past. That's where I would probably use a combination of a 6-monthly denosumab with a 2 years of teriparatide, and then continuing 8 years of denosumab thereafter at 60 milligrams subcute 6 monthly. So this is how I address this. Of course, this has to go hand in hand with vitamin D3, calcium, etc., modification of lifestyle, exercises, brace to protect this construct for at least 3 months, and 2 yearly DEXA scan. So this is the way I go about treating these people.
Right, sir. And in the same breath, sir, we have one question regarding the medical management. Any new line of treatment for osteoporosis? That is from Dr. Prajwal from
But
Bangalore.
as of today, this is where we are in India. There are certain other drugs which are in the pipeline which have not yet come in. Monoclonal antibodies of the next level above denosumab, plus certain other drugs which are similar to and can be given less frequently than parathormone. Parathormone is a daily drug. These are drugs which are coming in, plus strontium has a limited role. So these are things which are still in the pipeline, not yet introduced on a regular basis in India. Again, we must understand all these drugs are for osteoporosis and not for fracture healing, not for bone pain reduction. Both those things are off-label use, and those are bonuses that we may get over and above treatment of osteoporosis.
Right. Thank you so much, Ram sir. We may now move on the second case discussion by Dr. Ankit. And thank you, Sri, for a wonderful case discussion.
Thank you, sir.
So let's move on. I have another case here. So she's again an osteoporotic 71-year-old lady complaining of back pain since 40 days. She have had a trivial fall at home 40 days back and got treated for that locally. She now has bilateral radiating pain in the lower limbs since a day. On examination, has grade 4/5 power in both the limbs. Sensations and reflexes are normal, but she has incontinence since a day. There is no issue of any fever, weight loss, anorexia, or any past medical significant history. So these are the X-rays that were taken when she had fallen 40 days back and treated conservatively. So we see that there is a L2 insufficiency fracture. Both the end plates seem to be damaged along with the vertebral body. Dr. Shreel, what is the difference that you see in this X-ray as compared to the one that you had presented just before? Any differences that you can?
Exactly. So the difference is in the morphology of the fracture. There, the fracture was there was a collapse in the lower end of the fracture, with the fracture line running just superiorly to the lower end plate of the vertebra. But what here we can see is that the fracture has fully collapsed, and and it is mostly seen in the upper end plate, just below the upper end. The body of the vertebra has collapsed here, making it a vertebra plana.
And here we see an anterior break as well in the cortex, as well as ballooning of the posterior cortex, as I had said. If you connect these dots and then they see this is how much the body has moved behind.
Yes.
So what will be your line of management here? Like you will continue treating conservatively, or you will investigate further?
No, if this is a previous X-ray of the patient, then I would right now want a new set of X-rays and investigations, sir, to see how the fracture is right now behaving. And I would also want some blood investigation along with tumor marker profiles and arthritic marker profiles.
So DEXA and MRI also has to be added here because she has a recent onset neurological deficit, or you can just wait?
Yeah, no, we should add. If she has a neurological deficit of recent onset, we should do a MRI and an SOS contrast also.
So what kind of X-rays will you advise now, since you have already had one X-rays done previously and which shows insufficiency fracture with a burst component? What X-rays would you prescribe? Just a DL spine, dorsal lumbar spine, epilateral, or a whole spine scanogram, or supine setting as we have done in your previous case?
Sir, if you are going with this X-rays, I would ask for a DL spine, epilateral, and supine sitting also, flexion extension supine sitting also, and a screening of whole spine would give me an idea about the remaining part of the spine.
So here we should be conscious and alert that she might be having other fractures as well. The previous doctor might have done a limited study and have had picked up one fracture at L2 level, but she might be having a different fracture proximally, which might be the cause for the new onset neurological worsening. So here we should go ahead, do a limited DL spine supine sitting along with the whole spine scanogram to see if there are other levels as well. This is the, you can see here the supine sitting X-rays. So what do you see here as compared to the previous X-ray?
So yes, so there's as compared to the previous X-ray, in sitting position, the vertebral body has totally collapsed, and there's a progressive kyphosis of the spine, which is noted, sir.
So let's move forward. We did the blood administration, as you had rightly said, and she had low serum vitamin B12 levels and vitamin D3 levels, but everything else is normal. So what do you suspect here? Is she a primary osteoporosis with a trivial fall and neurological worsening, or you need to investigate further? What do you like?
So we need to investigate further. So we need to have a look at her MRI and the DEXA scan also.
The DEXA score here was minus 3.2 at the lumbosacral spine. So that means she is severe osteoporotic and never has been treated previously for osteoporosis as well. So here we do an MRI, and this is MRI here. So what do you see here? Dr. Sameer?
Yeah, so as mentioned by Dr. Sheel, there is probably non-union as well as ballooning of the posterior cortex of the 5, 4, 3, 2, I think L1 vertebra, which is being fractured. There is edema on the T2 sagittal images, and there is collapse of the posterior cortex as well as the anterior cortex. There is an hemangioma probably which is above, as well as one more old fracture which can be seen in the whole spine screening. Six level above. So over here we can clearly discriminate. The above fracture is probably old. And the reason for her present disability, especially the neurological compression which can be seen caused by the L1 vertebral fracture, which is ballooning into the spinal canal.
Posterior element insufficiency here, you see. What images sequences would you like to see that?
So probably stir images as well as the axial images will help in assessing about the posterior ligamentous complex. Over here, there is no hyperintensity which are seen in the axial as well as the sagittal images per se.
So how will you go about next? Like, she has recent onset neurological worsening. We have the MRI now. We are seeing that it is a compressive kind of a fracture. She has instability. So what line of management are we looking at right now?
So as compared to the previous case, this case is definitely, it is not even an elective surgery. I may say the patient is developing progressive neurological deficit since last one day with gallbladder incontinence. She has had all the red flag signs for which we should consider emergency or urgent surgery, at least in this patient. And the options of treatment which you have highlighted, vertebroplasty is definitely a no-no. It is a contraindication in this patient because the posterior cortex is probably ballooned as well as the patient is having a neurological deficit. So I would definitely go for an open decompression, stabilization, and maybe supplementing the anterior column with bone graft or cement.
So can we do the same procedure that Dr. Sheel had done in the previous case, like vertebroplasty and MIS fixation and decompression?
No, I would probably go for a proper posterior open decompression in this patient because she is developing a neurological deficit now.
True. So if theoretically she didn't have any neurological worsening, could we have done a long segment MIS fixation, or is it a bit difficult when it comes to osteoporotic patients?
It is pretty difficult in osteoporotic patients, but definitely an MIS fixation is not ruled out, particularly if the patient is having only dynamic symptoms and dynamic mechanical back pain. So in this patient, we can fix the patient in the position that she is not having symptoms, that is particularly extension, and then an MIS fixation would be preferable in those patients.
And since you have chosen an open formal posterior decompression and a long segment fixation, are you in favor of doing an anterior reconstruction also, or just a vertebroplasty or bone grafting through the transpedicular route?
So seeing the radiographs and the MRI of the patient, I could see a good edema which is being present on the MRI, which can be seen, as well as on the X-rays. It is kyphosing and collapsing. So basically, it is an intravertebral cleft, which probably we can fill it with a bone graft or cement in this particular patient, and which can give proper anterior column support. And this can be done easily with a transpedicular approach. And obviously, a long segment fixation. This patient is osteoporotic. Maybe 3 levels above and below would be optimum, rather than
So
the
when
usual
you
2 level above and below.
So why is it so? Like, what are the literature evidences and what is your experience behind that? Why do you choose a 3 level as compared to a 2 level fixation? Can you augment with a different kind of screw morphology here and still go get away with 2 level fixation?
I would definitely think about the 3 level or 3 level fixation. But yes, I will keep cement augmented screws, sublaminar wires, and all other modalities of fixation as a backup and on table. But my primary plan will be definitely 3 level above as well as below. The reason being, these are osteoporotic spines, and 2 level above and below, especially at the junctional level, there is a very high chances that the screws might not hold into those butter bodies. So in these patients, it is very much necessary to augment the mechanical support with the help of more levels of fixation. I would also go for probably corticocancellous screws, larger levels of fixations, larger diameter screws, longer screws, as well as supplement them with cement based on the hole that I'm getting intraoperatively. And last but not the least, always keep sublaminar wires and hard shield as a backup.
Yes, to add to that, we can even use hooks at the proximal level so as to have a better tension band.
Right.
And try to preserve the midline, which will also be of help, and try to go unilaterally and do the anterior decompression. So, any takers for anterior reconstruction alone, Dr. Sai, will you try and do anterior reconstruction with a cage and do directly body screws, which was being done quite frequently in the earlier decades?
So if we see a opening up, or if you see an anterior defect, a large defect, then we would think of the anterior reconstruction. But I think in this case, where there is a clear neurodeficit and a severe osteoporotic patient, I would like to go posteriorly and do decompression. And as Dr. Samir said, that I would like to do a bone grafting inside the cleft, and what is the defect is, which can be done transpedicular. And yes, to go 2 or more levels, which is 3 above and 3 below. And we usually prefer using dual threaded screws, which are the screws which are available for, and larger diameter screws.
Basically, you will prefer to do all posterior fixation decompression as well as anterior decompression from the posterior side in order to prevent the mobility.
Correct.
Yes, and avoid a dual stage procedure. Okay. So that is what was done by the surgical team here: a long segment posterior decompression and stabilization with pedicle screws. They chose a vertebroplasty and also did a biopsy. If you see here, the surgical team has restricted the usage of the fenestrated screws with cement to the proximal 2 levels only, and rest levels they have put in thicker diameter, longer and convergent screws. The patient has very well recovered logically and is working independently. So any signs of risk that you have while putting a fenestrated screw, you can see here in the screw, Dr. Steele, especially at the proximal 2 levels?
Yes, so what we can see here is this cement has leaked out. So this might be a defect because of the screws, because of the screw, which may have, which would not have contained the cement while injecting the cement. So the cements have leaked out over here.
So basically, it is very much important for us to know if there is a cement leak, and that is why you should be having a good fluoroscopic control and keep on checking. If you see any signs of epidural leak or anterior leaks, you have to stop injecting at that level.
Sir, I want to ask you over here, do you think that if you plan for a cement augmented screws, doing a decomp later and then putting a screws early would be a better option, or just to prevent spillage around the theca?
You can very well cover the theca with gauze pieces and patties and prevent any direct leakage onto that. The main concern here we have is that these are non-decompressed levels, okay, and we have no way to see if this cement leakage is going to cause any new compression. Okay, the surgical team will decompress this level. So here we need to be very vigilant, and at the very initial sign of any leakage, we need to stop injecting. So the learning points here are that at the time of the trauma, the vertebral fracture was very subtle, but within the span of 2 months, the patient has had almost 100% collapse of the vertebral height. So basically, most fractures, though they heal with collapse and deformity, a lot of them can go into non-union, have pseudoarthrosis with instability and persistent pain, and ultimately lead to late onset neurological deficit and loss of function. So the learning points here from this surgical particular case was that we should be using increased length and diameter of the screws when we are doing an open fixation. Threads should be engaging the subchondral bone to have more purchase. We can be using dual threaded screws along with French threaded screws. Utilization and triangulation of bilateral screws is a must. If you are in a routine habit of tapping, try and do under tapping so as to have more bone stock, have more bony fixation points as said by Dr. Samir, and always go 3 up and down. Use cement augment screws. Always have sublaminar wires and hard shell rectangle to your side, and most importantly, start anti-osteoporotic treatment as recommended. Thank you.
So before we close the case, let us ask Ram sir as to what would be his modality of fixation if this patient would have presented.
Well, as far as I am concerned, I would agree with what Dr. Ankit has done, but very rightly mentioned, we should always have a hard shell sublaminar ready in these situations. And this would ideally be an open vertebroplasty, which means that I would pass this cement, and probably this surgical team has done an open vertebroplasty. That's why they managed to keep it in the anterior half of the vertebral body and stayed there. So they have been very, very vigilant at that level. However, as rightly pointed out by Dr. Shreel, there's probably a cement leak to a certain extent, which was arrested and stopped, and the surgical team probably gave up. These don't look like fenestrated screws, so they might be wanting to actually cement standard screws, and there might have been some attempt at doing it which didn't work. So that's how it is, and it looks fine. I agree that dual core, dual thread screws do give a superior hold. Longer screws give a better hold. Some people believe that staggering screws up and down give a better hold. Bicortical gives a better hold. So these are all various things and ways of augmenting the screws. People use screws plus wires in addition at the areas where the laminae are still there. Unfortunately, wires which have tensile strength are stainless steel. Titanium wires don't really, but you can get certain cables with tensile strength which could be used to augment. And right on top, you could use hooks to prevent a PJK or a proximal junctional kyphosis, which is prone to occur in a lot of these long constructs. So this is in a nutshell about this particular case, but I think it's a well done case.
Right, sir. So, in continuation with the question asked by Dr. Ankit, when do you prefer to go anterior vis-a-vis posterior?
Excellent question. I prefer to go anterior till about 2005, 2010, when I was very aggressive. And I believe that all neurologies should be addressed anteriorly, and you should not address them from behind. And I was enjoying doing my anterior surgeries. However, over a period of time, I have realized that these are patients growing older, more moribund. Anterior approaches can be more difficult as far as the longevity and life of the patient is concerned. And we are achieving a lot from behind. And the paradigm shift now has come in doing a posterior shortening procedure, which we must keep in mind is an integral part of a lot of surgeries, where if you do an adequate posterior decompression and shorten the anterior column from behind, it makes the anterior void smaller and even amenable to either a bone graft, bone substitute, or a couple of drops of cement, or a small spacer put in from behind. So all these options are there if you do an anterior column shortening. That is what dawned and shifted me from the front to the rear in a big way. Again, please understand the anterior vertebral body is the weakest. The posterior laminae are still stronger. So between putting a large chunk in front, which will sink into the either vertebral end plates, which it did in my hand for many, many years, and I've learned from those mistakes, I now tend to go more posterior with a shortening procedure.
Right, sir. So as we know now, there are lots and lots of options surgically to treat this patients, be it vertebroplasty coupled with MIS fixations, open decompression stabilizations, long stabilizations, anterior corpectomies, anterior stabilization with the help of bone grafts versus vertebroplasty. And there are numerous questions or doubts that this case has raised in our minds. And to clear that, we have the final lecture by none other than our master, Ram sir, to talk about osteoporosis and surgical management.
Thank you very much, Samir. I am going to now, in brief, share technical tips about few procedures which would be an adjunct to management of osteoporotic vertebral fractures. My friends have given an excellent presentation, and we are all aging, and we believe that we should add life to years rather than years to life. Unfortunately, a trivial fall can change the entire sequence of events. This is an osteoporotic vertebral compression fracture of the L1 vertebra. In short, what do these people need? Minimum rest in bed, especially in absence of neurology, with a proper orthotic device for pain relief and ambulation. Suitable medication to be initiated in conjunction with a physician, geriatrician, or endocrinologist. Pain relief as an integral part. Take the help of pain specialists or physiatrists if necessary. Sitting supine x-rays become critical at around 6 weeks. Avoid them in the first 6 weeks because they will be very painful. If at 6 weeks the patient still has residual pain, more so a transition pain, biplanar x-rays sitting supine, confirm the instability. Is the instability intracorporal within the body or intercorporal between two vertebral bodies is primary, and we need to decide. Intracorporal needs intracorporal procedures within the body. Intercorporal would need procedures going across vertebral bodies. Check the D3, B12, calcium, serum parathormone, serum creatinine. Do a DEXA BMD wherever possible. Do a serum protein electrophoresis for M-band and rule out if there is any kappa lambda chain ratio which is distorted, and rule out multiple myeloma. Do a CT scan or an MRI, and always, when in doubt, find out if there is any suspected neurology or thecal compression or a pseudarthrosis. Having said and done that, initiate medical management, regular calcium, vitamin D3, HRT or SERMs, bisphosphonates, teriparatide, and now the new kid on the block, denosumab. As per indication, and it will be an integral part of treatment, whether it is medical or surgical. Let's look at this patient. 6 weeks, the same lady who had a fall. Subacute situation. There is an element of a fluid cleft, collapse with cleavage sign called Kamal's sign, better seen on a CT scan. Now we have to plan the purpose of treatment further. Why are we going to treat this patient? We have 5 points to look for. The pain that she has, instability she has, transition syndrome, getting in and out of bed, neurology if any, deformity if any, like a kyphosis, or she also has severe osteoporosis and multiple fractures, including the appendicular and axial skeleton. Let's look at only the axial skeleton and treat surgically osteoporotic vertebral compression fractures, there are 5 procedures that can be done. Either a percute cement augmentation, a posterior stabilization with indirect decompression. Where do we do this? Patient in lying down position can have an active anti-gravity SLR. The moment you make her sit or stand, she becomes weak, which means on sitting, on standing, there is an indirect kyphosis and a thecal compression, which needs to be made straight. These people need only a stabilization to give them the position of a correction of the kyphosis, which is an indirect decompression. Those which have profound neurology, acute onset especially, proper posterior decompression with a stabilization in C2, especially those who don't have a gross deformity. Those who have a deformity in addition, decompression, stabilization, and anterior reconstruction. The word is anterior reconstruction. Whether you short it, whether you put in cement, whether you put in a spacer, will vary from patient to patient. And finally, severe osteoporotic, everything is broken, even your screws don't go in, it's bone like butter. That's a salvage procedure. Let's begin with the first, which is just a percutaneous vertebro or kyphoplasty. Next is indirect decompression with cement augmentation with posterior stabilization. Third is direct decompression stabilization with, in this case, we used a bone substitute transpedicular about 15, 18 years back in situ. Next is open from posterior long segment. And finally, a salvage procedure using sublaminar wires and a stainless steel heart shield ring. Steps in percute posterior procedure. Delay it for at least 6 weeks. Why? A lot of them will resolve pain-wise. Pamper them, handhold them. Next, at 6 weeks, those breaks which are going into the vertebral end plate or anteriorly will actually close, and you'll have a nice fluid-filled cleft into which you can put cement more easily and do not have any leakage of the cement. Use local anesthesia, prone position, aseptic precautions in the OT. Use a linear incision, not a cross incision. Use 2 image intensifiers. Plan uniportal or biportal entry on the axial CT or MR of the Kamal lesion. Aspirate the fluid. That goes for fine needle aspiration cytology, but it also gives you an idea of the volume that can be injected. When I pull out about 3 ml, I know that I can inject 3 ml of cement. This is usually a clear, transparent fluid of pseudarthrosis. Use the cement, vertebroplasty cement, which is low exothermic cement, in an erectile phase. What is erectile phase? When you push it out of the needle, like a toothpaste, it will come upwards and doesn't fall down like liquid. Use a lure lock on a Jamshedi needle. I use multiple 2 ml syringes. Positioning of the patient, 2 C-arms. Request your colleagues to allow you to use 2 C-arms on that day. If you're doing it under local anesthetic, identify the common sign on the axial view. Use 1 or 2 Jamshedis or vertebroplasty needles. That's the erectile phase of the cement. 2 ml cement in a 2 ml syringe with a lure lock. Always have simultaneous imaging of AP and lateral views. And finally, you can inject and see both of them on your C-arm image intensifier. Moving to the second procedure, posterior stabilization with indirect decompression. These are either long or short, 1 to 3 levels above or below. If it's 1 level above and below, you can use a direct way that you can go in with the devices available, called sextant or its variants. If it's multiple levels, it's called longitude or its variants. Maximum length screw, maximum diameter, variable thread, hydroxyapatite coated if available, cemented or fenestrated if available. Strategically place the screws, multidirectional, tri-bicortical, under tap, use titanium. Have a low threshold for percute cement augmentation. That means even after you put them in, put a little bit of cement in either the fractured level or adjacent levels above or below. You may use a non-ionic contrast or a myelogram to check if you have got a decompression without opening the canal. I used to do this very regularly in the past, where I used to correct the mild kyphosis and then put in iohexol and see the free flow, so I don't have to open the canal and be sure that I've got a good indirect decompression. This is the same patient. That's the patient we showed earlier, where we went in, put in less than 2 ml of cement, put in the sextant, railroaded that small rod on either side and completed the procedure. Mind you, this lady had a bypass in the past, and if you see, her aorta and the major vessels were calcified. It was a touch and go procedure. Moving to posterior decompression with stabilization in situ. One of the most common things we'll do, it's usually long, occasionally short, but I prefer to go longer. I don't try to overcorrect the kyphosis. I accept whatever is correctable. I do a limited open decompression. I send biopsy from there for a frozen section to rule out malignancy. Again, have a low threshold for open vertebroplasty, especially the anterior and middle column. I don't allow my cement to come behind. I do an open vertebroplasty, and I may use transverse connectors or facet fusion in the area around the fracture. Let's look at this patient who came to us many, many years back, initially conserved for almost 3 to 6 months till she developed neurology, sphincters. I had to go in from posteriorly, decompress her, stabilize her, and do a long posterior decompression stabilization with a transverse connector. This is almost 15 to 18 years back. Now let's move to posterior decompression stabilization with an anterior reconstruction. These are usually long constructs, like the case that was shown by Dr. Ankit. We may do a posterior column shortening to reduce the anterior void. The residual anterior void, you can put a little bit of cement or put in a spacer, as I was saying, titanium or PEEK. I used to do anterior transthoracic, transdiaphragmatic retroperitoneal approaches, which I've almost given up today. I use hybrid augments like hooks, wires to supplement the rods. This is what I used to do about 18, 20 years back, where an osteoporotic fracture like this got almost fully corrected by a posterior stabilization. Something that corrects so much would be grossly unstable. Hence, I went in and put this large mesh cage. Today, I don't believe in doing that. What I believe in doing today is doing a posterior shortening for this procedure and getting that anterior void reduced to what it was by doing a concertina collapse from the rear. And if necessary, as in this patient, augmenting it with a little bit of cement in the anterior and middle column, anterior half of the middle column, and posteriorly supplementing it with screws. Why did I give up the procedure to the right? Because of what I said. I used to have a lot of these cages getting into the end plates and the late onset kyphosis. Am I happy with the posterior shortening procedure? Yes, I am, and I'm very, very confident that it will stand. Finally, if it's a very severe osteoporosis, keep your heart shield ring and sublaminar ready. Keep your cement augmented fenestrated screws ready. When you're putting in your heart shield or putting in your wires, unlike when you're doing it for any other surgery like TB spine or tumor, here you have to keep the entire laminar edges virgin. Don't use your kerrison on the laminar edges. Keep them intact. That's the strongest part of the bone, the laminar edges, so that your wires can go around. So you can do an interlaminar flavectomy and get in. Put in these wires, keeping the laminar edges intact. Again, in this case, I don't necessarily put cement. I allow the concertina collapse. So a very high threshold, not a low threshold for cement. I avoid it because the heart shield arouses micro motion and settling. It is an internal brace and always needs an external orthotic device. So as I said, either I cement augment my screws, I even use percute cement in addition, especially in this patient who had an hemangioma below, or if it's severely osteoporotic and bone is like butter, I would keep the option of a long hard shield sublaminar as I've done in this patient. My final message: subacute, painful, stable osteoporotic compression fracture around 6 weeks, vertebroplasty. Dynamic instability with only postural neurology. As I said, lying down, she can lift up her leg, but she buckles when she stands or sits. Posterior stabilization with indirect decompression. You want to use iohexol, use it to confirm it, but a lot of them don't need that. They remain decompressed. Significant neurology. Posterior decompression with limited open decompression behind and a long construct from behind. Neurology with deformity, posterior decompression stabilization with an anterior shortening or a limited anterior reconstruction, spacer or cement. And those with severe osteoporosis, suboptimal hold of any implant, get in your sublaminar wire, put in your long heart shield ring, let there be a concertina collapse, and let the patient wear a brace. This is what is most important: customized bracing and medical management, and your patients will live long, live happy, and smile forever. Thank you very, very much for a patient hearing.
Thank you so much, Ram sir, for walking us through each and every step of the surgical management of osteoporosis. I would like to hand over the proceedings to Ram sir once again for the vote of thanks and any further discussion.
Thank you very much, guys. It's been a pleasure and we've had a great time. If there are any questions in the chat, or if any of my colleagues have any questions, I would be happy to take them. Any of you, Shreel, Saijot, Ankit, Samir, any pearls of wisdom or any queries, we'll be happy to take it before we wind up.
Sir, is there any role of bone morphogenic protein in a non-healing fracture like the first case which we discussed with a Kumel sign and a content vertebra?
Beta, BMP is not really being used intracorporally or intercorporally. We only tend to use it in the posterolateral area of the spine because it tends to form new bone in areas which are perineural. Hence, BMP is avoided. But you could use something less than a BMP, like demineralized bone matrix, DBM, which does not have osteogenic, but has more of osteoconductive and osteoinductive abilities. But it does not throw new bone in an area which is perineural or epidural. But using BMP, which is RHBMP2, is a little bit double-edged because it may throw too much of bone and cause secondary neurology.
Thank you, sir.
Any other questions? If not, on behalf of Dr. Samir Ruparel, Ankit Patel, Saijot Raut, and Shreel Korala, I thank Anil Fernandez, Shekhar Getae, Minalji, and the entire team of Science Integra and Integrace who have put this whole event together and have given us the opportunity to share the little that we know with a lot of our colleagues. Thank you very much, and over to the organizers for all that they have conducted over 4 major sessions. Thank each one of you, my dear colleagues and the organizers, for making this educational effort fruitful. Thank you so much.
Thank you very much, sir, Professor Ram Chadda, and all our esteemed faculty, Dr. Samir Ruparel, Dr. Saijot, Dr. Shreel, and Dr. Ankit. I would say it's been a great pleasure listening to the deliberations that we've had today, and not just today, but for the entire duration of this 4-installment program. I think it's been very comprehensive and it's taken us through a very complete spectrum, right from conservative management to the surgical side. And today in the management of osteoporosis, I think we had very lucid and elaborate discussions, which could be great learning for the young generation of orthopedic surgeons who aspire to be spine surgeons. And looking into the importance and the value of such sessions, we at Integrace, sir, are looking at archiving it. And while the sessions were on, I was in parallel discussion with my team to see if we can, put them into some repository like BeConnect Health, so that it could be accessed by a number of young surgeons across our country. Thank you so much, sir. Your passion is really evident in your treatment and in your approach. And it's such a delight to listen to you and your wonderful team on all the aspects which are so well and simply elucidated. And I'm sure all the tips and tricks that all of you have shared from your vast experience will be a great value add for our viewers to apply this in the scenarios that they would encounter in their practice anytime tomorrow or anytime in the near or distant future. So we at Integra, sir, are deeply indebted to you and to your esteemed team for such high quality content. And we look forward to the pleasure of sustaining such a value added association for the benefit of the medical fraternity in our country, to whom we at Integrace are deeply committed to. And on behalf of Professor Ram Chadda and the team, Science Integra and Integrace, we would like to thank all our viewers for their patience and taking the time out of their personal schedules or professional schedules to make time and listen to the deliberations today. Thank you so much, and wish you all a wonderful evening ahead. Thank you so much. A pleasure and a delight to listen to each and every one of you. Meenal, over to you. If
Yes, sir. Thank you, Mr. Anil. Thank you for the kind words, and thank you for such a wonderful series of webinars that we had, the Bounce Back series. It was right from the day one of this series. It was extremely exciting and very, very knowledge adding to all the doctors and the fraternity. On behalf of Science Integra, I thank the esteemed faculty, especially Dr. Ram Chadda, to take this series ahead and have a very good concept right from the first series itself. And we have come to the last series with an immense set of knowledge being dispersed to the medical fraternity. And we thank Integrace Ortho for their valuable contribution to spread this knowledge to the doctors. Thank you so much, and sir, good night to all of you, sir.
thank you, sir. Thank you, all our esteemed speakers.